Good morning, everybody. Good morning, Satish bhai.
Good morning. Good morning. So we are now live on YouTube. We wait for a couple of minutes more. Usually we start 5 minutes past 8 o'clock. So let us wait. We have Baroda Management Association in Baroda, where I used to participate as chairman of the healthcare committee, and we used to have a lot of programs on quality care. We had two national conferences also. Jagdish bhai would also remember that.
Yes.
Nowadays we don't do these activities, but in our conferences this topic does come up. It does come up time and again, and there is a lot of movement for accreditation now. People look forward to laboratories which are accredited, hospitals which are accredited, and there is a rule also now to get NABH accreditation if you want insurance empanelment.
Yeah. One important conference we had was on individual practice versus group practice versus corporate practice.
Yes. So we used to compare various models of practice.
Various models of practice.
Yeah. I think a lot of things have come through what we predicted at that time. So we had a conference which was labeled as practice in 2020 that we held somewhere in I think 2007 or 8. And that time I think we had quite well predicted what is going to happen to various practice models in our region.
Jagdish bhai, Dr. P.N. Ghai in 1990 came to our KGP hospital, and we had started the Baroda branch of Indian Hospital Association, which Kamas and I, Jitu bhai, are still part of it, and a lot of training programs are being arranged. And when I was part as a clinical administrator, medical administrator of HCG, I got a lot of training for NABH, JCI, and got exposure. But thing is, now, yesterday only we had a protest that all these norms are closing all the hospitals which are serving 80% of the public. So there is a paradox also.
Okay. Eman, thank you for that input. It's 5 minutes past 8, so we'll start the meeting now. So welcome all to Saturday Club morning meeting. Today we have very interesting topic and very interesting speaker as well. We have Dr. Sapna Patel Keel. She's MD FACP from USA. She's Program Director, Internal Medicine Residency, Ascension St. Agnes Healthcare, Maryland, USA. She has a very long CV actually. I tried to summarize it in few points, few bullets, like several honors and awards she has been receiving, several administrative posts she has held. Recently, she is member Accreditation Council of Graduate Medical Education, Residency Review Committee for Internal Medicine, Chicago. She has been involved in teaching of undergraduate medical students, resident teaching, and to her credit, she has several research publications and has written chapters for books. And of course, she is a very popular speaker. And she is going to speak about high value care in healthcare. So we are very eagerly looking forward to you, Dr. Sapna, for this little unusual topic for our Saturday Club. So over to you. You have about 40-45 minutes, and we'll allow 10-15 minutes of interaction also. So over to you, Dr. Sapna.
Thank you. Thank you so much for inviting me. This is indeed an honor. I've always heard about you all from my father, and so this is a great thing for me to do. So I hope that this topic interests you, and you are able to get something out of this to take to your own practice. So I'm going to talk a little bit about not just quality care, but high value care today. And some of this curriculum comes from the American College of Physicians. And we use this often to train our new physicians as well as our current ones. So my objectives today are to talk about and define what high value care is and how we can use that. Introduce a simple 5-step model that can be used to deliver high value care. We are going to discuss the cost implications of some few common clinical scenarios. So I'm going to give you some examples on how you can use these principles when we make appropriate diagnosis and determine treatment. And then identify some clinical reasoning tools that will help us manage uncertainty that is part of making diagnosis and treating our patients. So we are very lucky to live today. If we had been born 100 years ago or another time, life expectancy wasn't what it is today. We were lucky for most people to live into their 40s or 50s, but that has changed dramatically in the last 50, 60 years. And thanks to so many new advancements, not just in medicines, but in technology, in our understanding of how the body works, that we are in a different era of healthcare and an era where we are constantly changing and learning. But when we look at healthcare across the world, what are the countries where people live the longest? And you might be surprised to see that 2 Asian countries top the list at Japan and Singapore. And then you have a few European countries. And Canada is the lone country from North America that's in the top 20 countries by life expectancy. And if you look on the lower chart, you can see it's around age 84. US is nowhere to be found on this. And you may ask, why is it that the United States is not doing as well as so many other countries? And if you look at not only life expectancy, which is on the y-axis in this, but on the x-axis, you will see health expenditure. And what you will see is that over time, 1970 is right here, and here's 2014. And what you see is the red line is US, and life expectancy is improved, just like all these other countries, but not as much. And we spend significantly more money, but we don't get as much life expectancy as all these other countries do. You can see Japan topping it right there. So for all the money we spend, which is way more than all these countries, we are not making those differences like we should be. And why is that? And that's multifactorial for the US. And I think it's a good lesson for all countries to learn from. How can we do this better? What's frustrating is that you will find that US will trail other rich countries in life expectancy. So while most other countries are going to have very high life expectancy, for example, in 2030, if you're a South Korean woman, you're expected to live to 90. In the US, it's around 83. So there is still a big gap. And why is that so? It's not just in life expectancy. It is also seen in maternal mortality, in pediatric outcomes, in all groups. America has lagged behind. Here you have the maternal mortality deaths on the y-axis and how much money we spend. We keep spending a lot of money, but our mortality, maternal mortality, has not changed. In fact, it is actually worsening. Some of it is because women are having kids later on in life, but we are still not making the same outcomes as we should. So one of the advantages of technology is all this longevity and good quality of life we can provide, but it comes at a very high cost. And we look at the expenses, US spend about $3.8 trillion in 2019. In 2020, because of COVID pandemic, we spent slightly less, but now we're back up in 2022 and steadily rising. That means we're spending about $12,000 on average per person annually. So every man, woman, and child in America, we're spending $12,000 per person. That is 18% of our gross domestic product. So a very high percent and not a sustainable trajectory. Something that India should look at also, that as we advance in technology and we provide better care, how can we control costs moving forward? And so the US national health expenditures are predicted to continue to grow and grow and grow, as you can see in this map. So patients sometimes come into the US and in our patient clinics and in our emergency rooms and say, look, I can't afford that diagnosis. Do you have a cheaper one? Basically, our healthcare costs are just skyrocketing out of control, and we do have to find better ways to control them. Where does this money go? Well, a third of it goes, more than a third, goes to hospital care. Hospital care obviously is more expensive with ICUs and intensive management of patients. But there's also costs related to clinical services, medications are very expensive, and then a small amount for everything else in relative percentages. Why should we worry about costs now? Because it's not just that the costs are rising, but we also are well aware that the US, 1 in 3 healthcare dollars are wasted. So we have a huge opportunity to save money and still provide good care in America. So why are we wasting money, and where is this waste going? Well, a huge percent of it goes in unnecessary services. So what are unnecessary services? We'll talk more about that as we move forward. But administrative costs. So once you start having private health insurers and insurance companies, now you have to have people who call and ask for money, and paper pushers and administrative staff to manage to get the money you need to take care of patients. We also don't do a good job in delivering care in all the right places or at the cheapest level. Prices are very obscure in America. So when you go to a hospital, no one will tell you how much it's going to cost for any test. Doctors don't know, the staff don't know, so there's no way to know what you are getting for your money. There is no other industry that functions like that. It would be like trying to go buy a car and not know how much the cost is till you actually got the car and were driving it. It's very hard to function with that. Prevention is a big thing. We don't prevent diseases well. We spend a lot of money once you have the heart disease and putting in stents and putting in defibrillators and all the latest technology, but we don't do as well in prevention. So when you look at the waste, out of that big bucket of waste, about half of that waste is physician driven. So my focus today is to focus on things that we as physicians, doctors would be interested in. What are the things we can do to improve care? And so here are the opportunities where we can play a role in giving less unnecessary services, not missing opportunities for prevention, and then delivering care well. So the waste domains are, as I talked about, failure of care delivery coordination. Sometimes we overtreat in America. We will replace joints when we could continue to work with the joint you have. but will replace because there are many perverse incentives. Because if you're spending a lot of money, there are a lot of people also making money within the system. We don't do a good job with pricing, as we talked about. But today we are going to focus much more on this overtreatment or low value care. So what do I mean by high value and low value care? Well, by high value care is just a simple equation. How can you get the best quality possible for the lowest amount of cost? So that's high value. And I think that's what we all want, is to be able to provide that kind of care and what we want for ourselves. And cost is not just money. Cost is also non-financial harms, where we may create anxiety or stress for our patients, or make them go through additional unnecessary procedures because we find, say, an incidentalloma on a CAT scan or a spot on the X-ray. And so now we start doing more and more testing. And it was not necessary at all. So low value care is where we also prescribe a lot of medicines just because patients want medicine. Give me something so they feel like they've gotten something as they walk out the door. And so antibiotics are overprescribed for a lot of viral infections, for common cold and sinus and this and that, a lot of times because patients want something to take with them, and we provide that. We screen, we test things, and in the last 6 months of a person's life in the US, almost half our healthcare dollars are spent in those last 6 months of a person's life. And most Americans die in a hospital, not at home. And when you ask most Americans, where would you rather die? They all want to die at home, surrounded by loved ones, not in a hospital. Yet, that is where most people end up dying in the US. So when we think about why we, as physicians, especially when we have trainees and when we're teaching, why do we over-order tests? There are many reasons. Cognitively, if we were to think about it, we often, if we're not comfortable with the diagnosis, we're going to order more tests. We may not even realize the cost of the labs that we are asking our patients to do. We may not be thinking about cost and harm, and we want to be complete. Sometimes it may mean we are rushing. Let's order everything so that they can go to the lab, get all the lab tests done. Sometimes we duplicate tests. The senior resident orders tests, the attending orders the same tests in the computer, and they don't see that they're duplicating. Sometimes there's faculty or their attending will ask them for a test. Or there's defensive medicine in the US that people don't want to be sued. Or patient requests is another very common reason. So about 10 years ago in 2012, the American Board of Internal Medicine in the US came up with what they called Choosing Wisely. And they started this campaign now where all the different medical societies have joined, including pharmacist societies and other paramedical professionals who have joined to come together and say, we need to get a handle on this. And physicians must lead in addressing this problem because we do know best what our patients need and what is unnecessary. And when physicians are surveyed, most of them agree that this is a problem. I think we can all think of tests that are over-ordered or things that are done that aren't necessary. In America, we have what we call the Quadruple Aim for healthcare. So certainly we want the first aim has always been about patient experience, making sure the patients can get the care they need. Second aim has always been around population health. How can we improve outcomes? And then cost is the third piece. How do we make sure that we can afford the system we are making? Medicare will go bankrupt in the next dozen years if major changes are not made in the US. So we cannot have a system that is not sustainable. The last piece is making sure that the nurses, doctors, staff are supported and work in a quality improvement culture. Every few years, the Institute of Medicine in the US puts out reports like this. So quality stuff came out in early 2000s, and with the first report, which was called To Err is Human, and then the Crossing the Quality Chasm. The one in 2015 was around best care at lower costs. And these are all free reports that are put out that help determine the direction in which research and investment in infrastructure is made in the US. So here are the 5 steps that we could go if we are trying to practice high value care. We must understand the benefits and harms and the relative costs and try to get rid of things that aren't useful. So for example, a few years ago, we stopped doing creatinine kinase, CPK-MB, when troponin tests became very popular, and they're so highly sensitive and specific for myocardial ischemia that we stopped doing some of the other things that we used to do, myoglobin, CPK, CPK-MB. All these tests were unnecessary. We were just ordering them because it was easy to order. Sometimes it's hard to take away things that we are used to doing. Then we just keep adding more tests as new advances are made. So looking for those opportunities to subtract things from the way we provide care is highly important too. And also recognizing that our patients don't want to die hooked up to machines and getting lots of unnecessary care. So we make sure we understand our patients' values and incorporate that. So I'm just going to work us through a couple cases and we'll talk about them. So here's a simple case, but a common one. A 35-year-old woman comes to your office, say, or to the emergency room complaining of headaches. Headaches every 1 to 2 weeks for the past few months. The headaches are sometimes preceded by seeing spots and are associated with nausea. They're often right-sided. They're pulsatile in nature, and they last about 4 to 8 hours. And she cannot identify any triggers that bring these headaches on. Fortunately, in medicine, we have what we often call our red flags. Red flags are things that should alarm us when a patient gives us that information in the history, and we should seek that information. So in this case, the red flags would be if the headache was, she never had a history of headaches and they first started and she was over 50, or if there was a change in her typical headaches, or she told us it's the worst headache of her life, or she has a history of cancer, immunosuppression, or HIV, or there are fevers or other systemic illnesses with it, epilepsy. There's an abnormal focal neurologic exam, or there's a personality change, or symptoms that last longer, or any symptoms of intracranial pressure. So what if this patient did not have any of these flags? Would you still order any imaging to further evaluate this patient? Well, in the US, if you went to the emergency room, people will often, like this with headaches, will first get a CAT scan. And sometimes they're not even seen by a doctor. They'll be seen by a PA or a nurse practitioner, and they'll already order a head CT. What are the costs? So there's a wide variation in the US, and you can see I accessed this data in 2018 to give you an idea that the minimum price of a CAT scan can be $750, but the maximum can be in the thousands. And when you look at MRI of the brain, that can be even higher. And even the insurance pays, insurance doesn't pay all of it. And if you don't have insurance, you have to pay cash out of pocket, which can be very, very expensive, as you can imagine. This is something I looked up just a few days ago to find the costs around where we live. And so they said the fair price, and you can look this up, called Blue Book, and you can see where the costs are. So for migraine headaches, instead of directly going, which is what we think this lady's diagnosis is, you can use criteria called POUND. POUND stands for pulsating, duration of 4 to 72 hours. It's unilateral, associated with nausea, and can be often disabling. So people need to go and lie down in a quiet room because oops.
No, sorry for the interruption. Somebody was. Please go ahead.
So, so if you look at that, then the likelihood ratio in POUND criteria could tell you that if you have most of these criteria, and this woman has 4 out of the 5 criteria, then the likelihood ratio that this is a migraine is 24. So you can get likelihood ratios based on sensitivity and specificity of different criteria. And if it is high, like likelihood ratios over 10, 15, then you don't have to do additional tests. You just document that this is where the patient is, this is why you're doing this. And it also provides you some legal protection should the patient come back and sue. So where do these kinds of criteria come from? Well, here's one of the places you can go. Choosingwisely.org is something that I think is a great place to go. But this is put forward by the American College of Radiology. And what they found is there's a lot of unnecessary testing done on CAT scans for headaches. And so don't do imaging for uncomplicated headaches. Similarly, they say, don't image first for suspected pulmonary embolism. Start if there isn't a moderate or high pre-test probability based on established criteria, then you don't have to go to a scan first. You can start out looking at those criteria. Choosing Wisely was a campaign that started, like I said, in 2012. And they partnered with something that's very popular in America. It's called Consumer Reports. It's a magazine and company that looks at products across America. So if they look at all the different soaps, for example, for bathing, and they'll tell you what are the best quality soaps and the highest value soaps. So best quality for the lowest cost. They'll do that for televisions, for cars, for all sorts of things, all kinds of products in America. And so they decided to partner and say, why not do it for healthcare also? How can you choose wisely? So they want to promote conversations. So give doctors the tools to talk to patients and also give patients information. So patients will come and say, so doctor, this is what I read. What do you think? So patients can choose care that is supported also by evidence, and it's not duplicative. And it keeps you free from harm. I think we've all seen patients who may have died or had a bad outcome because people went for a biopsy or went for something when it wasn't probably necessary. And the patient suffered, say, a pneumothorax or had a complication or a bleed that could have been avoided. So truly necessary care. And all different societies of all different specialties have partnered to come up with 5 things from their each specialty that they can tell you about. So for American College of Physicians, they said, we should not be doing screening stress tests for patients who are low risk just because they're going for a procedure or anything like that. If they have non-specific back pain, it's the most common complaint. People come to doctors with back pain. You don't need to do all the x-rays and CAT scans. If they don't have any red flags like neurologic symptoms, fevers, things like that. The patient has passed out and they have a normal neuro exam, we don't need to do also all this testing that we often typically do in America. Other things they said is if patients have a low pretest probability of thromboembolism, then just get a D-dimer first. If the blood test D-dimer is abnormal, then you do the imaging. If it is normal, because it is so sensitive as a test, you can essentially rule out pulmonary embolism. And you don't need preoperative chest x-rays, which we often did in America 20 years ago. And now we're trying to do a lot less. So if patients has no symptoms, you don't need to do a chest x-ray every time they go to the operating theater. Similarly, hospital-based medicine, they have similar things that they recommend. So using Foley catheters for incontinence or for convenience of nursing staff so that bed linens are not soiled, that is not good care because that promotes infections. We also in the US give everybody a proton pump inhibitor or an H2 blocker for stress ulcer prophylaxis when they're admitted to the hospital and they're older. You don't need to do that because there's no good data. You don't need to just give blood transfusions if patients don't have symptoms. So transfusing to a number is not useful. Transfuse to symptoms. There should be no telemetry outside the ICU without a protocol. Sometimes you put patients on telemetry and just leave them on it. It's much more expensive. And we also do routine labs for patients who are admitted every single day when it's not necessary. So looking at places where we make mistakes, where there's extra waste, we should be paying attention in our practice, in our hospitals, in our systems, and look proactively for where there are places where we can reduce costs, we can eliminate harmful things. And we should also incorporate patients. So many hospitals have patient committees or patient representatives who work with hospitals to improve care and give perspective of a patient or patient's family. Diagnostic uncertainty is to be expected in medicine. We have to take the history and try to come up with a good hypothesis. And if we are not confident, then we should pursue lower testing, but we should have people be knowledgeable about protocols and algorithms so that you don't have to order a lot of testing every time. When we are uncertain or we don't have good knowledge, we're more likely to order tests. And we're more likely to spend a lot of money. And every time we are more uncertain, we spend more money. And it's not always for the benefit of our patients. So we must always look at additional testing and look at downstream effects. And there are many more now specialty-specific validated clinical decision support tools. So when you go in electronic health records in the US now, a lot of times they will ask you a lot of questions and say, before you can even order a test, they will ask you, does the patient have this? Does the patient have that? And only if you are able to truthfully say that the patient has these things, then only you can even order certain tests, because otherwise people were just ordering a lot of things that are not necessary. And we know that when there are financial incentives, not just in India, but even in the US, when you are making money from the testing you're doing, then people are more likely to use those tests. So here they're looking at cardiologists and physician billing and cardiac stress testing patterns following coronary revascularization, even when patients have no symptoms. If they have symptoms, but they're not billing. So the green are the people who are not making money. When you can see all the people who are getting professional fees or technical money, if you're getting it, you're much more likely to order the same tests. So clearly physicians are driven by this, and we know that, and we should be very careful about this as well. So let's talk about another case. Here's a 23-year-old woman with no past history, and she comes in with acute onset colicky right flank pain. She has no fever, but she's a little tachycardic when she comes in. She is in moderate distress, and she has costovertebral angle tenderness. Labs show a mild white count elevation, and the urine dipstick shows trace leukocyte esterase, trace blood, and your urine cultures are pending. Now you're thinking as a doctor, maybe this is pyelonephritis, maybe urolithiasis, but you want to confirm it. So what imaging, if any, do you want to order at this point? If you were to go to the American College of Radiology appropriateness criteria, it will give you some support tools of how to make that decision. And here, the higher number is something that's more appropriate, versus a lower number like 1 to 3 is usually not appropriate. So let's take a look at this person. Here, if you look, here's the radiologic procedure, here's the rating, and here are some comments. Here, a CAT scan without IV contrast is a very high rating. Here, they recommend reduced dose CAT scan, right? So no CAT scan is benign. Every time you scan someone, you are exposing them to radiation. And we know over time, more CAT scans you do, the more radiation exposure patients get and more likely they are to have cancer. It is not unusual in America for people who come in with abdominal pain, off and on in emergency room, they'll get a CAT scan every time. Some patients may have 10, 20, 30 CAT scans in 1 year of their abdomen. We have no idea how much that radiation exposure could cause damage. So in this person, even a KUB or urography or an ultrasound are low ratings because they are not as sensitive in helping us decide whether there's a urolithiasis or pyelonephritis there. Of course, no decision support tool is perfect. There are limits to it. We have to use them appropriately. You have to have good clinical knowledge to make sure that the population is the same. Sensitivity must be high for high-risk conditions. And if it slows down your workflow and patients have to wait a long time, they're not going to wait. So we have to make sure that there are appropriate tools. And at the end of the day, clinical judgment is very, very important and is not to be supplemented by this. So American College of Radiology came up with what is called R-scan, and you can type that in your search engine like Google and look up. And they talk about how we can reduce waste and not overscan people. So in this patient, that young lady who came in with the fever and the white count, an X-ray of her abdomen was done and it did not show anything. She was treated for a urinary tract infection with antibiotics empirically while we were still waiting for urine cultures. She continued to have pain and her urine output decreased. Renal ultrasound was performed and hydronephrosis was identified. The patient underwent a CT arterioportography without contrast, and we found an obstructive right renal calculus. Urology was consulted and the patient underwent lithotripsy. Initial hospitalization costs: ciprofloxacin, the scan, KUB, the renal bladder ultrasound, and the pelvis, CT abdomen pelvis, and the lithotripsy. A 4-night hospital stay, $12,000. So as you can see, it can be quite expensive. If we don't make the right diagnosis, and patient could be coming in and out of the office, multiple emergency room visits, more imaging, more antibiotics, and more problems. And so CT scan in this case was the most expensive test, but it was the right one to order, because high cost doesn't mean you shouldn't order the test. High costs not necessarily equal low value. In some scenarios, high cost is the right test to order because it gets you to the answer the fastest and saves the patient angst and delays in care and leads to better outcomes. So high cost interventions may provide good value if they are beneficial. So it's not just because it's expensive we should wait to do tests. We should do the right tests at the right time for the right patients. So similarly, we have the Geriatric Society that goes through and tells us about things. So it tells us don't use antipsychotics. We use them a lot with patients who have behavioral, psychological symptoms of dementia, because we have found that while they do help manage behavioral issues, they may cause patients to do poorly and lead to increased mortality in older patients. We should not be doing very tight control of diabetes in older patients because we may run the risk of having hypoglycemia in older patients. And when you have hypoglycemia in older patients, that can lead to worse outcomes. Also, a lot of times, bacteriuria is very common as we get older. So if you take older patients, everybody's urine is going to have some bacteria. So we should not treat every single person whose urine is positive, but see if there are urinary tract symptoms and only treat those. So one last case that I'll walk you through as well. Here you have a 48-year-old man. He's evaluated in the emergency room for left flank pain and dysuria. 6 months ago, he had acute gallstone pancreatitis and had been hospitalized. And a contrast-enhanced CAT scan then showed lack of perfusion in the pancreas. Fortunately, he survived, did very well with supportive care, and was discharged from the hospital at that time. And then a few weeks later, once the pancreatitis had calmed down, he underwent an uncomplicated laparoscopic cholecystectomy about 4 weeks after discharge. And now, about 6 months after that, he is coming to us and he has sudden onset of left flank pain. On physical exam, blood pressure is pretty good, 130/80. Pulse is 90, other vital signs are normal. And the abdominal exam is just notable for some pain in the left lower quadrant on palpation, but otherwise the exam is normal. Urine shows some hematuria, and the CAT scan identifies some nephrolithiasis and a small stone in the left ureter. But there's also something else you find, a 6-centimeter fluid collection with solid debris in the body of the pancreas. And that fluid collection has a well-defined wall. What do you think is the most appropriate management of this fluid collection? Would you start this patient on antibiotics? Would you put a needle in it and try to figure out, is this infected? Is this cancer? What is it? Would you do a drainage procedure? Have your interventional radiologist in the US, they would put a small pigtail catheter, or one of those thin catheters, let it drain out. Or should you just stop and observe this patient? So in this case, the best thing to do is to observe, because the patient isn't toxic appearing, the vital signs are normal. And what this patient has is a walled off necrosis. And when you have necrotic pancreas, you don't have to always actively treat with antibiotics or stick needles in it. If it's well walled off, let the body do its job and just let it be. And you can, in a week or so, repeat the CAT scan, see how the pain, manage the pain. And we would keep this patient in the hospital maybe a couple of days, make sure everything's okay, and let them go home. We would not give antibiotics because they're not indicated yet. And even with a small stone in the left ureter, you don't necessarily have to treat if it's not obstructive. So in summary, when we think about high value care, it is important for us to recognize that in healthcare, there's a lot of waste, and it's an urgent multi-billion-dollar problem. And if we are not able to control costs, all these advances we have made in healthcare will be for nothing, and people will not be able to afford and get the best care possible. So we must make sure that at system levels where patients are getting the right care, and we are, as professional societies and as doctors, making sure that we are deciding what that right care is. We do know that when doctors are not sure or not confident in their decision making, they spend a lot of money and waste a lot of money. And so it's very important to keep doctors, while they're practicing, updated on evidence-based guidelines, newer advances, so that we are able to help with the practice of high value care. And so I ask you in your practice, or if you can think of times where you have seen waste or opportunities where we could change the culture or system to provide high value care. That is all I had. Thank you so much for your time and attention, and I'm happy to answer questions.
Thank you, Dr. Sapna. That was excellent. A very comprehensive view on how we should practice as far as our cost and value quality is concerned. So thank you so much for a very comprehensive presentation. You may stop the screen sharing and we can take some questions from the audience or comments from the audience. First, I look at the chat box where there's a comment and a...
Wait, let me just stop share, sorry.
There's more of a comment from Dr. Sulin Trivedi about Hippocratic oath, rational versus irrational greed and phobia of CPA. So there are always views on this, like say, what are the reasons for the unnecessary expenditure that we do in patient care? You already highlighted that financial perspective is also there when we decide about what are we doing with our patients. So any more comments or questions from other people?
Is this scoring system available for most of the problems we face?
Yeah, so there are, for many common diseases, scoring systems available and algorithms available. It's just people are not always aware of them, or when you're busy, it may take you a little time to stop and look and check. But yeah, there are a lot of these algorithms available, but we have to do a good job getting that history first, so that we know which algorithm is the most appropriate one. But yeah, we are increasingly asking people to use them. And with the electronic medical records, we can push patients, we can push physicians to walk through certain criteria before they can even order a test. And we have seen that we can reduce the use, say, of CAT scans in the emergency room by making the emergency room physician walk through and answer a series of questions. And it leads them down a path and tells them this is the test to do.
Can we compare this with what we call as antimicrobial stewardship? When
Yes.
every physician is audited and monitored.
Yes. So we do a lot of antimicrobial stewardship as well at our hospital. So one of the ways we do that is we look at how medicines are prescribed and who is ordering too many antibiotics compared to other people. We also look at what type of antibiotic choices they're making. And we select random group of 10 patients per doctor, and we'll look and see who's ordering, is it appropriate, we give them education. So antimicrobial stewardship and making sure that people are narrowing the spectrum of organisms that is covered as soon as you know what organism you're treating. So we have what's called BioFire, which is another machine that allows us to do rapid PCR.
We also do have that.
Reaction, exactly. So we can easily identify the organism right away within hours of a patient coming in. So we know it's E. coli, or we know it's methicillin-resistant Staph aureus. So we know that we have to choose that type of antibiotic right away. And we're not waiting for cultures to come back, which can take hours to days. And meanwhile, the patient gets what we call big gun antibiotics. So using a cannon to kill a fly, right? We don't want to do that with antibiotics. We don't want to do that with other tests as well.
So when we talk about these things, rational use of diagnostics and therapeutics, there is always an issue of compliance by the consultants. And in the disguise of clinical freedom, what they call as our clinical freedom, they get away with a lot of irrational things. How do you manage that in your setups?
So we also do that for our consultants. So each of our subspecialty also has to monitor within there. So say our gastroenterologists, so then we make them look at random cases for each. And a group of them, they have to analyze them and show us that they are looking at the care provided by their specialists. It is hard because it's their own friends, right? But what we do is we have them de-identified. So we say only they know what number they are. So physician 5 is ordering too many of these tests or doing things. Now physician 5 knows who they are, but nobody else knows who physician 5 is. So that helps sometimes because nothing gets people's attention. We are all creatures. We are very social creatures, and we want our peers to respect us, and we want their approval. So using numbers like that, people don't talk about who they are, but they hear what their friends are saying about their care, then they usually get in line.
That's wonderful. So there is a sort of a system of medical audit in your setup, it seems, right?
That's correct. And I think we have to do that because how can we all know we are doing the right thing? Because we are in our own world, seeing patient, moving to patient after patient after patient. If we don't stop and look at each other's care, we don't know what we don't know.
Very true.
Satish bhai.
Yes.
But now, one aspect is the mind of the patient. And one of the physicians said, the disease is directed by the relatives, the mind of the relatives. In India, there is a problem of plenty. Like there are plenty of doctors who are competitors of private practice and plenty of tests which are easily available. So the mind of the patient or relative says, do all the tests so that we are relieved that it is not there. So the answer lies, I think, in your very good simple line that everybody should get an algorithm for each and every symptom, and each organization like surgeons or pediatricians, at least for the 10 commonest presentation, they should have a walkway, or what I call it a step ladder things. The easiest answer to this is every physician should end his prescription that if not relieved, you should get few tests done or come back to me.
That's true.
Yes, very true, very true. And we have to, as physicians, be the drivers. So, and we know in our own specialty where the waste is, and we also can know where the challenges are, what are difficult diagnoses to make versus the simpler ones that most of us can ensure that everybody uses the less resources for. In terms of families and we have the same issue here in the US too sometimes, where to appease children of older parents, oh, go do this, doctor, I don't want to have to worry about this or that. You have to spend a lot of time explaining. And so one of the things that this Consumer Reports does is it's a good example we can use to tell patients that, look, when you're going to buy a car, you're not just going to buy the first one that's bright and shiny or the one the salesman is going to tell you about. You're going to look at what's under the hood and make sure it's a good car and it's the right one for you. And so similarly in healthcare, you are coming to me because I am an expert on telling you what's under the hood of the car and what's right for you, not just what looks bright and shiny. So let me explain why this is the best one. And so here, and you can go yourself to Consumer Reports site and see what information is there as well. So a lot of times in the US, and I'm sure in India, people go to the internet and become Google doctors all the time.
Yes, a lot of them. Everybody does that. So I think it boils down to the individual clinician and physician to have an introspection, spend more time with the patient to explain, and then take bold decisions. No, he should have that courage of conviction that what I'm doing is. So one of the slides, you portrayed very, very comprehensively. You analyze the reasons for irrational use of investigation, and one of them was cognition and knowledge also. So we need to keep updated. Many of us are not keeping updated, and that's why we are falling prey to using unnecessary medications and diagnostic tests. That is also one of the biggest factors.
I totally agree. We have the same issue here too. It's easy to keep doing what you're comfortable with and not have to change. But change is part of life. We have to keep updated.
Yeah, like Dr. Jagdish Bhai and Satish Bhai and Amin Sahib. Even if they are not practicing, they are keeping themselves updated. So inspiring.
Yes, indeed. We never stop learning. The day you stop learning is the day you die.
Right.
As my father would say.
So wonderful session, Dr. Sapna. I think we'll have you more often because we all like the way you presented this topic in a very lucid manner, very simple and very easily understood. So thank you so much. So we end the session here. We end the session here and we meet again next Saturday morning. Thank you all. We end the session. Thank you.
Thank you.